Good morning, everyone, and welcome to Within's Continuing Education webinar series. My name is Ashley Barkowiak, and I'm the Clinical Operations Coordinator here at Within Health. Welcome, everybody, to this wonderful CEU and CME credit that we have available for you all today. Before I get things started, I want to introduce our speaker today. Our speaker is Rebecca Brumm. She is our Chief Clinical Officer here at Within Health. And just to give a little bit of background on Rebecca, she is, again, like I said, our Chief Clinical Officer. She also attended Central Michigan University. She is passionate about the mind-body-soul connection. Her leadership style as well as clinical approach reflect these values. She has helped clients through a variety of challenges in her practice as a therapist since 2005. She specializes in people work to improve their body image, that heal their relationships with themselves, and also overcome eating disorders. So again, welcome Rebecca to our talk today. Before we do kick things off, we do have some general information to go over in regards to the CEU and CME credits. I will now pass things over to Jamie to go over the CME credits.
Thank you, Ashley. Good morning, everyone, and welcome to our CE presentation today. My name is Jamie Singletary, and I am the Director of Clinical Brand Development for Within Health, and it is my pleasure to be here. I just wanted to briefly go over housekeeping for how to obtain your credits for today's presentation. For those of you that are looking to get the CE credit, you will get that through your CE Go dashboard. Your dashboard is going to be your best friend. This is where you will get your CE certificate along with an evaluation that will be emailed to you using the email that you use to register for today's talk. Once you complete the evaluation, you will receive a link that will take you to where you can download your CE certificate. For those of you that are getting CME credit, this is typically for our medical providers. If you will email me directly, I will then email you the instruction on how to obtain your CME certificate. I will have my email in the chat today, and you can utilize the chat to ask me any questions that you have regarding the certificate. Also want to make sure that you utilize the dashboard because we do have handouts that are going to run with today's presentation. In those handouts, you will have references to points that Rebecca will be making as far as suggested readings, along with links that you will be able to access. So again, this is for CE credit. Utilize the CE Go dashboard. And if you are looking for CME credit, please email me directly and I will provide those instructions. Thank you.
Wonderful. Again, for the CEU credits, you will be seeing an evaluation come through in your email that you registered for the presentation. Once you complete that evaluation, you will find your CE certificate, again, as Jamie said, on the dashboard. So please utilize that dashboard for anything CEU related. We will not be providing the slides today, but a video of the presentation will be available after the presentation is completed, and that will also be in the CE Go dashboard platform. The credit will only be given to those that attend live today. And again, to access that video that will be in your CE Go dashboard, that handout, as Jamie mentioned, will also be available. That has links that will be provided during the presentation. So if you would like access to any of that information, please utilize that dashboard. If you do have a tech issue during the presentation and you need to change any devices, you will receive credit for that. And for any additional questions regarding obtaining the credits, if you have any issues accessing the provided handout or links, please feel free to email myself or Jamie. I will provide both of those emails in the chat. And again, if you have any questions that come up in the presentation that you would like to ask Rebecca, please utilize the chat or the Q&A feature, and we will get those questions answered. And now I would love to hand things over to Rebecca.
Thank you guys so much. I really appreciate the way that you bring everything together, and you're such a resource for the people that are here. Thank you everyone for attending today. I love schema therapy work. And I feel so thankful to be able to have the opportunity to share this with all of you, because it's been such a fundamental core part of my work of 20 years as a therapist, of learning to understand patients and understand how to best help them. So just a quick note, thank you for the introduction, Ashley. I have the opportunity to be the Chief Clinical Officer at Within. I've been a counselor for a long time, since 2005. It's wild to me that it's almost 20 years. I have done a lot of my career in eating disorder work. And the perspective that I'll speak to you from today is really through that lens, as being certified in intuitive eating, having basic and advanced training in IFS, and basic and advanced training in Schema Therapy. And at first glance, those IFS and Schema Therapy is a CBT approach, and IFS is much more experiential. They have, at first glance, had kind of different flares to them, but over time, I really saw that they can work so well in conjunction and kind of give the best of both worlds, from that kind of fundamental CBT lens, but also starting to being able to get to know the patient a little bit on a deeper level. Because I don't have this in my resources for all of you, I want to be able to share it with you right now. The introduction for me to Schema Therapy, and a tool that I have found that is really accessible for patients, is this book that's listed right under the Schema Therapy bullet. So it's called Navigating Your Life: The Breakthrough Program to End Negative Behavior and Feel Great Again. It's actually written by Jeffrey Young, who is the founder of Schema Therapy. I always like to put the title in, because it's not something that if you Googled Schema Therapy, you might wander upon right away. So this is the name of the book. If you are looking for an introduction to Schema Therapy, this is a great way to start. It's also very accessible to patients. So when I use Schema Therapy, I will often recommend this book to them as a way to really read one chapter about the schemas that they're really activating highly on, and they can come back to session and have a really insightful discussion about some of their understandings about their schemas that are active in their lives. Okay, so what I hope that you'll get from today, I want you to be able to define and differentiate early maladaptive schemas. I want you to understand what schemas are, how they developed, how they impact your clients' emotional regulation skills, and their coping strategies and what they turn to for coping. I would like you to leave with knowing the assessment tools that are available through Schema Therapy, how you can access them, how to provide them, and then how to utilize them in your work with clients to help you and help them understand more about how they cope and understand why they cope the way that they do. And then lastly, the bigger chunk that we'll spend some time on today is how to put all of that information together to facilitate corrective emotional experiences. So I love that phrase, because that's really what we're working to achieve as clinicians, is these corrective emotional experiences between the vulnerable, hurt parts, the wounded parts that are part of us, that serve to kind of uphold some of the core dysfunctional beliefs that we have, and help the client to build a healthy adult that can help to correct some of those experiences. One piece that I didn't mention in here is I think that Schema Therapy for me as a clinician has really served as what my sons would call cheat codes. They can be gamers sometimes, and for me, Schema Therapy is an early way to help to identify how a client functions, what their beliefs are, what their understandings about life are, maybe what experiences have led them to that. And then they help you to really kind of have a roadmap of understanding how this person might be operating. For the agenda today, we'll do a little bit of literature review just so you can see what's going on with research and what's out there. We'll also talk about the fundamentals of schema therapy. So I'm assuming that you're coming in with very limited knowledge of schema therapy. So I'll give you some of the basic tenets so that you can understand it. We'll talk about some of the assessments and how those can be useful for you. We'll talk about facilitating corrective emotional experiences for your patients. And then I have a spattering of case studies that are throughout this so that we can see it kind of in action and in practice. So this question here that I have for you, it is actually a dialogue that my team and I had just in saying, okay, what are the ways and the experiences that our patients need to have in order to find recovery? These are some of the things that we came up with. They need to be able to disrupt those behavioral patterns. They need to have some understanding about how their eating disorder behaviors and maybe even their eating disorder beliefs have been functional for them in some way, how they've served as coping patterns, perhaps, ways that they have felt that maybe the eating disorder has been protective of them. Our clients also need to learn how to meet their own needs in powerful ways. I have found over time that it can be confusing for our clients even to understand what might meet their needs. To recover from an eating disorder, individuals will often have to challenge those harmful core beliefs about their own worthiness, their own lovability, and their basic human rights. And we also felt like it was really important for them to have corrective experiences in an environment where there was some predictability about the loving and safeness of that environment so that they could feel free to explore those new patterns of behavior. So it's a really interesting question for a clinician to ask themselves. I'm always curious and would love to go back to the chat and see if there's anything that we missed, anything that you all might feel like is part of the discussion to add here. But it's one of the reasons why I like schema therapy so much, because I feel like it hits so many of these areas of experiences that patients need to have in order to find progress in their recovery. So let's slide into some of the research. So I like this here because it speaks to some of the pieces that we just spoke about. So there is a tendency for our negative core beliefs to be the underpinnings of an eating disorder. In fact, these negative core beliefs that are inherently connected to those who tend to suffer with eating disorders are emotional deprivation, abandonment, and self-sacrifice. So I want you to pin these in your mind. I'm going to circle back to these specifics. What I don't want to miss here is anybody who may be struggling with what a schema is. So a schema is a collection of beliefs of how the world operates, a pervasive kind of style of explaining the world to yourself. So these negative core beliefs are also interchangeable with schemas and really are the collection of beliefs and understandings that somebody holds about themselves, others in the world, that are really internalized. Researchers also think that these schemas or maladaptive core beliefs are understood as a risk factor for the development of an eating disorder and also a risk factor for the relapse of an eating disorder. So to me, I hear that as so important that we understand what the negative core beliefs are and that we help to de-entrench our clients from them as part of their recovery process. And of course, as you might expect, that holding these beliefs causes significant psychological distress. Okay, so let's move into a little bit of the fundamentals of, just make sure I'm trying to check. Okay, the fundamentals of schema therapy, what you need to know. So the core tenet of schema therapy is that there are needs that children need to have met in childhood. During this time, they need to have secure attachment. They need to be seen. They need to be heard. They need to feel loved and validated. They need to feel that they are wanted. They need to feel that they are safe and secure. They need autonomy. They need to have the experience of becoming their own separate person. They need to feel that who they are separately is respected. They need to have opportunities for that self-differentiation, that self-development. They need to practice receiving constructive feedback and validation of that separateness. They also need to have freedom to express their own needs and to have those needs validated. So the freedom to express what they like, what they feel, what they dislike. The ability to ask for what they need or want, the ability to make choices, and the ability to kind of agree to disagree, to kind of hold and maintain perhaps beliefs that are separate or distinct from their families of origin. They also have the need for spontaneity and play. They need to have space to be creative, silly, fun, to self-express in a free way for exploration and adventure, and have space to have accumulation of positive experience. And then finally, they also need realistic limits and self-control. They need to practice respecting boundaries. They need to practice and learn how to accept no. They need to learn to accept responsibility. They need to be able to respect the autonomy that this is mine and this is yours, and I can respect that safety and privacy and space that is not mine. I actually think this slide may be out of order, so forgive me for the herky-jerkiness here. I'm going to ping back to literature for a second here, and then we'll go in more fundamentals. So again, the literature for schema therapy and the conjunction of eating disorders shows that poor responses to treatment, which I think it should make all of our ears perk up, can be attributed to not taking into account the factors that went into the eating disorder's development, like the core beliefs that somebody might hold, not resolving those issues, and poor responses to treatment also can be attributed to the presence of entrenched schemas. Schema therapy can be a very valuable tool when CBT is not offering the treatment outcomes that you'd like to see. Schema therapy also is really known in the literature for complexity, cases that are more complex. There's a lot of separate literature and some overlapping literature around its usefulness with personality disorders, also its usefulness in treating forensic populations. So it really is known for being a sorry for that, that can support complex cases. All right, let me move on from there. I want to get you back to schema fundamentals. Okay, So some of the other fundamentals in schema therapy. So what schema therapy will use kind of interchangeably with schemas are this term called EMS, early maladaptive schemas. And that really is saying these are schemas that develop in early childhood. They are schemas that develop during a time where we have limited resources in just our ability to understand the world, in our ability to see the world and see factors in the world as the complex shades of gray that they are. And they are ways of explaining things that are maybe too complex to us to fully understand. So schema therapy says that early maladaptive schemas develop due to these unmet needs that we just talked about. Also, a tenet of schema therapy is that early maladaptive schemas are the roots of the dysfunctional beliefs and coping strategies that our patients have, and that these early maladaptive schemas come from wounded child parts. What I like about the way that schema therapy as a CBT intervention, its ability to see the complexity and to hold some of the beyond thought experiences of our patients. So an early maladaptive schema is a thought or a collection of thoughts, a theme of a collection of thoughts, but it's also containing memories or visceral imagery experiences, the emotional experiences of those memories, the bodily sensations that may go along with the emotions, or even with perhaps what might have been recorded as a traumatic or dangerous or stressful situation for that person. So again, early maladaptive schemas are broad. It's interesting because sometimes when you introduce this to clients, they'll see a pattern of how they have explained everything in their lives through the lens of the schema. And they'll start to see, like, kind of have fun with themselves, even seeing that everything that is triggering for them is funneled through this one belief system. So it's pervasive in the way that it's kind of your go-to when something is triggering for me. This is how I explain why that happened for me. Schemas also have to do with the relationship with the patient's self and their relationships with really the world and with others. These schemas are ones that develop early in life, kind of like I will often say to clients when the clay is really wet. So during early life, the clay is really wet. Some things are going to leave a mark in a more deep way than they might during times when we are adults, when the clay is more dry. So they happen during a time when the blueprint is being created. They have a tendency to continue to play out. And this is just something I find so fascinating. I think so much of our work, or my work as a clinician, and maybe your work as a provider, is being curious about patterns and ways that patterns can continue to play out, ways that patterns can present themselves in different scenarios. And when you have an understanding of schemas, you can really see how somebody's beliefs about something and maybe even their fear or protective coping strategies will in fact make something more likely to play out. So the schemas can be really self-fulfilling. And of course, with all of that, there is a level of this impairment and suffering that the person is experiencing while clinging to the schema. So just to kind of recap here, this is largely where schema therapy holds its foundation. So here you can see that there are unmet needs in childhood. And when these unmet needs are significant, they will result in a schema domain. So the next piece that we're going to move into is the schemas that fall under these domains. But I want to stop here for just a minute, and I want to check in to see, before we go into kind of a deeper dive, what questions do you all have about some of these fundamentals? What can I answer for you? What can I help solidify before we start moving into a direction of building upon?
I know we did have a couple questions roll through about references, but we will save that for the end so that way we don't have to lose place or anything like that in the slides. But you're getting some love in the chat and some inspiring and the great info that you're giving.
Thank you. Okay, yes, I'm a big, I know that this is probably the tip of the iceberg, and really truly the tip of the iceberg. So if you have questions at any point, please don't hesitate to let me know. And there's a lot of references at the end, a lot of references that are included in the handout, but I have more in my brain too. So if there are specifics, I'm happy to pass that along.
Perfect. We actually did have one roll through the Q&A. Can you give an example of a presentation that would indicate schema therapy would be a good choice?
Okay, so I'm a huge believer that there's a science and there's an art to what we do. So for me, I use, and I'm like a big toolbox, lots of tools in the toolbox kind of clinician. But for me, I will often utilize schema therapy with nearly everyone, so that I can get a really solid understanding from them of what are their patterns and tendencies with explaining the world. What's their worldview? I think that will make a little bit more sense as we go into some of the schemas. I did struggle a little bit with how to tell this story in the best way for all of you. So I'll give a little bit of it away. There is an assessment that you can give. I will usually give the schema assessment in the first or second session early on, so that I can, almost like an assessment tool, right? So I'm noticing that these schemas are active for you. Tell me about them. Tell me what beliefs, and I'll demonstrate all of that coming up here. But for me as a clinician, schema therapy, even though other tools might get pulled in, it's a way of making sure that in a really efficient way of understanding the patient and how some of their experiences have shaped the way that they believe, the way that they cope, and the way that they think.
Wonderful. Thank you, Rebecca.
Okay, I'm going to move on if there are no other questions. Okay, this feels like the juicy kind of parts to me. So the first domain is disconnection and rejection. So where these are the areas that kind of the fine tune of the microscope. So in the abandonment schema, so let me back up. Schema therapy is going to be, you're going to see the results of this inventory come back in these 5 domains. But there are 18 schemas. So 1, 2, 3, 4, 5. The first 5 are in the domain of disconnection and rejection. So somebody might score high on abandonment. So this tells me that they may have a pervasive belief that that everyone leaves them. They have a sense of loneliness, or an expectation that it's only a matter of time before somebody that they love or somebody that they care for will leave them. Mistrust and abuse, that others, and especially others that they let into their circle, or if they let them into their circle, will abuse them by or intentionally cause them harm by lying, cheating, manipulating, hurting, shaming, or some other way of abusing them. So they may hold the worldview that it's not safe to trust people. They might also hold a worldview that their emotional needs will never be met. This is often one that I see with the eating disorder population. So no matter what, they may not receive the nurturance that they need. They may not receive the validation or empathy, or they may not receive the protection that they need. And that no matter what, this is going to be kind of a deep unmet well for them. They also might have the schema of defectiveness or shame, the fundamental belief that they are flawed, worthless, bad, or otherwise useless. And the last area, the last schema is social isolation, or alienation. This is the perception of being isolated from others, being different, not being a part of the crowd no matter where they go, and really struggling with a sense of belonging. So again, the core need that was not met and led to or contributed to the development of this belief system is the need for attachment. So the next domain is impaired autonomy and performance. So the need in this area that was not met is autonomy or differentiation. And under these, the schema heading are dependence and incompetency. So this is the belief that the individual really is incapable of making the decisions that are best for them, that they require a large amount of support from others to fully be able to live their lives. And if it were left to them, they would be not capable. They would be potentially vulnerable. Vulnerability to harm, you'll see in the further literature, this is a big one that shows up in the research, in the literature with bulimia nervosa. This is a kind of a pervasive view that somebody held a vulnerability to harm, whether that's risk of illness, harm, or danger, and that they are unable to protect themselves from that. It's really only a matter of time. Sometimes you'll see somebody with health anxiety. Sorry, that's the word I was looking for. People with health anxiety will often carry this vulnerability to harm, and it's this pervasive worldview that it's only a matter of time before something bad befalls them. Enmeshment is also a part of this domain. This is really the strong attachment to others, the tendency to be over-involved, and to feel like the differentiation of self is less important than the collective view of a family system or other type of system. And then the last domain, or the last schema in this domain, is failure. So the belief that no matter what, somebody will always, it's just a matter of time before they fail. It's just a matter of time before perhaps somebody figures out that they are a failure and that they will never amount to anything. And if they are doing well at something, it's because it's a fluke, and it's just a matter of time before that shows itself. The next one is impaired limits, and the two that fall under this domain are entitlement. I actually see entitlement show up quite a bit, although it can manifest in different ways. But the entitlement piece is the belief that one is superior to others, and that they are deserving of special treatment and privileges that others might not get. The way that I see this show up a lot is in conjunction. I think that we'll go through it in a later slide. I see this one show up with a pervasive worldview of, if I hold myself to unrealistic standards, then I will be given special access, but special privileges that should entitle me to these things that others might not have. So I do see that show up a lot with eating disorder clients. And insufficient self-control is the second one that is in this domain. This is the difficulty with impulse control, with surfing urges. It may show up as risk-taking behaviors, or expressing emotions in a really extreme way, low distress tolerance. And the need here is for realistic limits, to learn how to challenge maybe some of the ways that this is getting, that limits are getting in the way. Maybe a belief that if somebody sets a limit with me, they don't love me. Or if somebody sets a limit with me, then I will never get the needs met that I have. The fourth domain is other directedness. This is a big one for those with eating disorders. So these three areas in the other directedness domain are subjugation. So this subjugation is really the act of giving control over to others to make decisions on their behalf. And usually it's from a belief that that person is weaker than the other person, or less capable than the other person that they're giving that control or power over to. Self-sacrifice is a big one. You'll see this in the case studies that I'll share with you. The belief that others' needs are more important than theirs, that others' needs need to be met at the expense of their own needs, even if that means that the expense is to happiness or well-being. And then again, as you can imagine, approval seeking is a big one as well. And this is the act of trying to get approval, praise, or attention from others at the expense of the individual's own feelings or identity. So the last domain is overvigilance and inhibition. So this can show up in a couple of different ways. Can show up as negativity and pessimism. So the tendency to hyperfixate on the negative aspects of life, to always anticipate the worst, and to minimize some of the positives. Emotional inhibition. So here, there's been a couple of revisions to schema therapy that are minute for our purposes. But one of them is for the forensic population. It's in emotional inhibition. It's been further divided into a pattern of emotional constriction. And this is a pattern of like being over controlled or disconnected from one's own emotions, versus the having of emotions, but the fear of losing control if those emotions are expressed. So one is I must keep everything locked down, and the other is I'm not safe unless I do keep things locked down. Unrelenting standards. I will say this one is almost a hallmark of our clientele. And lovingly, it's almost a hallmark of therapists too. So unrelenting standards is the belief that one must work excessively hard to meet very high standards for their behavior. That achievement is the most important things, or one of the most important things, to avoid criticism of the self. And then punitiveness is also broken into two categories now. Punitiveness can be focused towards others. So a hyper focus on if others make mistakes, they should be punished harshly for that, versus punitiveness towards the self. So if somebody is making mistakes, then they should be punished harshly because of those mistakes. Okay, so let's talk about how do you find out what your client might score with these. So this is in your handout. The links are in your handout, and this is an available inventory. The Young Schema Questionnaire is in the revised version, is has been revised in 2002. It used to be the YSQL. The L is what I used for a long time. The L stood for long, and it was very long. It was close to 300 questions. The R is now 116 questions that has the validity of what the L had. There's access to a free webinar on how to provide it, how to score it, and then access to the scoring as well. So what this is 116 item Likert scale assessment. And the reason why, I'm going to back up here, I added these for all of you in the notes and in the slides are because you can kind of eyeball this as you're going through if you know what these initials stand for. So when you have somebody take this assessment, you will notice that the schema questions are clumped together. And that is important to know as a clinician, but it's also important to set the stage for your clients too. So when I first started giving this, I would have people come back to me and say, I started it, but I just think, you kind of didn't get me because none of it really had to pertain to me. And so now I always explain that they should expect that a lot of it is going to be, does not pertain to 1, 1, 1, 1, 1, like this is not me at all. And then they'll get to a section of the assessment where they feel like, okay, yes, this is totally me. And then I explain it as this just helps me to know what kind of thinking experiences maybe you have the tendency to fall toward. So you'll see this on my next few slides. What I really like about it too is that you can pull out the belief that the person is endorsing. So when I say a 6, right? The 6 on the Likert scale is describes me perfectly, I think is what it is. So the 6 beliefs are things that I will pull out and say, tell me about this. So you said you endorse this at a very high level. Tell me where that belief comes from. Tell me maybe where you first learned that about the world or about yourself. And I also find that it's helpful and important. Sometimes I even say, I almost need you to like hang your rationality up on the wall for a minute here while we talk about some of these things, because schemas are really, it's not true, but it feels like nothing else could be true. And that I hope we all can have that experience. I also will say to them when the schema is activated for us, it can feel like we're looking at the world through a really dense fog. We know that there are things beyond the fog, but all we can see is the fog. So I would be remiss to not speak about culture in any inventory. So just a couple of things that I want to point out here. It's important to have a good understanding. I'm going to move us here to have a good understanding of the client's culture. It can also be in discussion and review of the schema inventory and the highly endorsed beliefs and statements. It can be a good space to have discussion and to learn more about how the person's culture might have shaped those beliefs. It's also a good time for discussion about healthy adult. So many different therapy and therapeutic interventions have this idea of the healthy adult, whether it's wise mind or healthy parent mode, the self, or the inner therapist. Like I've heard it described as so many different things. In schema therapy, it's described as the healthy adult, but it can be important to have a discussion about what the healthy adult is considered to be in their culture of origin, because sometimes the idea of the healthy adult might actually hold behaviors that the client doesn't necessarily feel are the healthiest for themselves. So it can be important to be able to tease that out. Another thing that I think actually is the reason why I'm so drawn to eating disorder work is the functional dysfunction of them. So always having the lens that a schema or the schema beliefs had some functionality to them at some point, even though they might be getting in their way right now. At some point in that person's life, the schema belief maybe kept them alive, maybe kept them afloat, maybe kept them safe in a situation that wasn't feeling safe for them. So it's really important that we consider the cultural experiences of things like racism, sexism, sizeism, and other forms of bias or hurt or trauma that could be at play for the individual, and consider the context in which the schemas might have served as a protection for them. Okay, let's do a bit of a check-in with you all, see if there's anything that you might have questions about before we move in a direction of understanding some of the eating disorder trends with schema therapy.
We did have a couple of questions roll through. The first one is, how do you typically identify patterns and themes? I've seen it done with client-developed life timeline.
Will you read that back to me? Just the first part, how do I?
Of course. How do you typically identify patterns or themes?
So I'm gonna go a little out of order here. So the inventory that you do, and then the scoring mechanism will spit out this graph. And it will identify them for you, really. So I want to circle back to this question when we get to it in the slides. And this is kind of why I say it helps with a roadmap, and it helps with a lens of just understanding, like, okay, they say that and they do that. What belief might they be operating? What narrative might they have that's behind this?
Perfect. One other question that rolled through was, what is needed for impaired autonomy, and what are the needs for domains 2, 4, and 5?
Let me back us up. And oops. So we'll look at the graph that I have there. So these domains, right? So when somebody has impaired autonomy, I can think of somebody that I worked with right off the top of my head, that said, I only ever wear solid shirts, even though there are things that I love. There are, in fact, he said there are games, gaming, gaming games, that I really enjoy, that I see the t-shirts of, but I don't feel like I can show myself, or I would be embarrassed to show myself. And so one of his schemas was in the domain of impaired autonomy. And one of the things that we worked on was like, who are you? What do you like? Is it safe for you to show that this is what you like? What happens if somebody doesn't like what you like? What happens if how do we handle it when somebody says, nice shirt, dork, those kinds of things. How do you feel at peace with the unique human being that you are? I think there were specifics about kind of all of these areas. And some of the corrective experiences are, and again, I'm going a little out of order here. So what, as working through the lens of a schema therapist, it's important to have is to say, okay, when I see where this person's schema inventory is coming back to me in, how do I visualize the little person who maybe didn't, through whatever experience they might have had. I'm a parent. I have an 18-year-old son right now, and it's a very humbling experience to raise a human to their adult time frame. I'm very careful to not blame parents, and I think that's really important in our work too. Humans raise humans, but for some reason they grew up in an experience where this didn't really get a chance to flesh out for themselves. And so how can they learn how to do these things, to bring these things into their lives in conjunction with their healthy adult self? So somebody who has an overvigilance and inhibition schemas, they often will, I'm thinking of somebody that I just spoke with about this, she felt very vulnerable to go and play pickleball because she knew she wouldn't be good at it. She only wanted to do things that she felt like she was going to be really good at. And if she wasn't good at it, that people would not like her and stare at her and be annoyed with her. And when we talked about her adult self, and she works in a school, and we talked about what she might say to the kids when they're trying something new. She was able to see a huge contrast between the beliefs that her schema held about looking stupid and never showing yourself that much vulnerability, versus allowing herself to go out and have fun and be playful and to be silly and be a dork and try something that she may not be good at just for the sake of having fun. And I think as we continue to talk about corrective emotional experiences, this will make more and more sense.
Wonderful. Thank you, Rebecca. And any of the other questions that we received, we can save for the end session.
Sounds great. Thank you guys for such good questions. I really hope that you're able to take away good information that will help you in your work. Okay. So trends in eating disorder populations. I talked about some of these, but let's talk a little bit more. Patients with eating disorders versus healthy controls, they have the tendency to experience more maladaptive schemas. And these are the trends that are seen in the literature: emotional deprivation, mistrust and abuse, social isolation, defectiveness and shame, failure to achieve, dependence or enmeshment, vulnerability to harm and subjugation. Another study found that abandonment and vulnerability to harm were also found in women with eating disorders. Here we tease out a little bit of some of the differences that we see in bulimia nervosa versus anorexia. Abandonment and vulnerability to harm were schemas that were more highly endorsed in another study with patients with bulimia nervosa. And in another study, it was found that patients with anorexia endorsed unrelenting standards, and that was connected to high levels of perfectionism. Okay, so let's talk about case study here. This is a patient that I did some work with. She's 47-year-old female, had an original diagnosis of anorexia restricting type, was in a residential setting for treatment 4 years ago, and now has worked down the levels of care. She currently serves in an executive position. She works long hours, often to the detriment of her relationship. Her spouse talks about having frustration about not being able to see her, about her prioritizing work often over other obligations and plans that they've had. She will report struggling in her personal time, meaning not being sure how to relax. She often will, when feeling successful or successful, meaning managing her life without too much chaos, she'll feel restless and look for ways to, and I say this lovingly, kind of stir up chaos in her life or stir up challenges for herself. Maybe it will be, deciding that she needs a promotion or deciding that she needs to tackle a big project at work. And her eating disorder behaviors have morphed a little bit into sometimes still doing restriction around the good foods. And please hear my quotes around that, that she believes that she should be having, while then simultaneously having times of subjective and objective binges with the foods that she believes are forbidden, and a lot of rumination around her being bad for doing this. So that history, and I'll show you what her reports gave me. So she took the YSQR, and this is what the report spat back to me. And as you can see, the ones that are the schemas that are presenting over the red line are those where they were very highly endorsed. She's got a few that are almost at the line, but for my work, I'm going to look first at these. And success in treatment would really mean bringing some of these down. So they might always, and this is true for all human beings. We all have these patterns and tendencies in our thinking. I will really encourage all of you to go take the YSQR. It can be really interesting to understand your tendencies in thinking. In fact, I love this topic so much that I'm going to do a deeper dive for our summit coming up in October that will be more geared for clinicians and understanding what we do, what our tendencies are in our thinking patterns, and then how those make combinations with different patients. And the importance of understanding that, and the importance of understanding the patterns that can sometimes result between our schemas and our patients' schemas. But for the sake of discussion today, what I want to circle back to for this client. So when I read through her inventory, I looked at her graph with her, showed her this, and helped her to understand what I was seeing. I also circled back to where she was endorsing some of the highest beliefs. So she said with self-sacrifice, she endorsed, no matter how busy I am, I always find a way to take care of others. And she also said, no matter how much I give, I feel it is never enough. So those two pieces were incredibly insightful and yielded really strong discussion for us in help me understand where you first learned that. Where was that modeled? Where was your first example of that? Where did you, how do you see that modeled in your life currently? What are you afraid will happen if you don't do those things? For unrelenting standards, she endorsed, I have so much to accomplish that there is almost no time to relax. I often sacrifice pleasure and happiness to meet my own standards. And she also endorsed, I strive to keep almost everything in perfect order. So again, discussion and insight around that. And then approval seeking. She endorsed, it is important to me to be liked by almost everyone I know. My self-esteem is based mostly on how other people view me. And unless I get a lot of attention from others, I feel less important. And she was able to identify that work was a big source for her to get this approval seeking, and that home wasn't always necessarily set up for her to get this kind of feedback. And so she felt more drawn to the work environment. Um, and she was able to have a pretty healthy discussion around what does the schema, what's the collection of beliefs that the schema holds, and how does that differ between what her healthy adult self holds. Here's another case study. This patient has a little bit of a different presentation. This was a 30-year-old female with active bulimia nervosa. She had a significant history of addiction and a significant history of trauma. She had co-occurring borderline personality disorder. And interestingly, she was a medical student graduate, but was really struggling to take the next steps in her career. So this is her schema, her YSQR report. And as you can see here, emotional deprivation, I'll never get my needs met. It's only a matter of time before those that I love will abandon me. Defectiveness is really high. Unrelenting standards is very high. And self-punitiveness is very high. And something I may say later, but I want to point out now, very similarly to, well, let me leave that there and come back to it. The holes that our patients fall into are not necessarily going to stop being the holes that they fall into. When they are doing work, especially with some of these entrenched, more like borderline or personality disorders, the goal is for there to be less activation, for the holes to be less deep that they fall into. They may continue to fall into the same holes throughout their lives, but our hope is that they will be able to get out of them more quickly, that when they fall in, they'll spend less time there. And that they might be able to say, okay, wait a minute, when something happens, I always explain it through the lens of this person's on their way out. But I need to recognize that that's my pattern to believe or to explain the world to myself. And it doesn't necessarily mean that it's true. I'm not going to go through the specifics just in our best interest of time. But of course, as you can imagine, there was a lot of discussion that really helped me to understand her better in the questions that she endorsed as 5s and 6s. We were able to circle back and say, help me understand why you believe this is true, why this comes up for you, how you have, how and why you've learned to incorporate that into your belief about the world. Okay, so let's use the last chunk of our time together to move into some interventions with this framework. This is one of my very favorite quotes that validates and normalizes the fact that we have multitudes as human beings. I am drawn to parts work, and parts work is not something that's unique in therapy. We've seen it in transactional analysis, we've seen it in IFS, we've seen it in Gestalt chair work. I'll do a little bit of discussion about parts work with emotion-focused family therapy. So I really would like to be able to normalize that work in therapy, and to marry some of these interventions with a cognitive behavioral framework to work from as well. So schema therapy really conceptualizes personality as a distinct part of potentially separate affect, cognitive cognitions, behaviors, and motivations. And when we think about parts, we can say, like, a part of me feels XYZ about this, and a part of me feels completely different. That's very normal. It's really normal that we can have thoughts and urges and behaviors that absolutely appall us and make us feel embarrassed that we want to do them. And we still have a part of us that wants to engage in it. I think that when we can embrace this, that our patients can understand they may have that part and they also have another part of them. So I think that when we can say, yes, part of you wants that, is there a part of you that feels any differently about that? We can use that to build the internal therapist or internal healthy adult self within them. Moving into corrective emotional experiences. What a great phrase that is. So in schema therapy, problems are envisioned as, or problems with emotional regulation are envisioned as these being captured in the early adverse childhood experiences. So I mentioned IFS. I like that a lot. IFS kind of has this idea that the wounded core parts of us are child parts that are kind of locked away. They're called exiles. So they're very in alignment with schema therapy, understanding that these core beliefs that can really lead to suffering for us are often childlike beliefs coming from a childlike understanding of the world. And that when we can bring in the adult skills or more adult skills and perspective, that we can shine a greater depth of understanding for that person, and that they can kind of heal their perceptions around those times where those schemas were created. The APA describes a corrective emotional experience as one that comes to an understanding, an experience through which one comes to an understanding, to understand an event or relationship in a different or unexpected way that results in an emotional coming to terms with it. So again, the goal really is to take a painful experience and look at the associated meaning, and to infuse the healthy adult mode into that experience to understand it in a different way. So I like to share a personal example of that. I identify myself as being recovered from an eating disorder. And in my own work, I did some work with my mom. So growing up, I have a sister who's 2 years younger than I am. Growing up, my mom, when she would get us ready for school, she would spend the morning with us, dressing us, often in matching outfits. I can picture this shirt that I wore with a jean skirt and a belt. And that feels like it encapsulates my childhood experience. And she would braid our hair, she would put it in hot rollers, and would always make sure that we looked completely put together. And what I took from that experience into my older years was that there was an expectation for me to always look perfect, that it was unacceptable if I looked anything different than that. And sometimes my mom would send me back if I didn't look the way that she thought I should look. She would send me back before I went out into the world to look in the way that she wanted me to. So in our work together, what I learned, revisiting these experiences and the beliefs that I took from that, and the forward beliefs in understanding what the expectations that others or that I had for myself or that the world had for me, she shined a light on the fact that as a young girl growing up, she was one of 5 children. She was the only girl, and she had 4 older brothers. And when she was growing up, they didn't have a lot of money, and they would often kind of go out and play and just get dirty and kind of be with boys the whole time. And she had a best friend that she saw that was kind of always dressed in a very presentable way. And they played a lot together. And one day her mother came out and said, "You may not play with these dirty little street urchins anymore." So the belief that my mom, the schema that my mom took forward into that, was that she would never let her children be perceived as being unloved. So that was a really corrective emotional experience for me, because I had ideas that I was not acceptable to my mom unless I was perfect. And really the corrective emotional experience was understanding the depth and the complexity that her experiences held, in understanding that it wasn't that I was unacceptable, being imperfect to her. It's that she didn't want to feel the discomfort of anybody seeing me as being potentially unloved by her parents, the same way that she felt like she had been seen. So these corrective emotional experiences let us see a real depth that maybe we're unable to see. So the healing work that takes place in schema therapy is really to reconnect us to those core emotional needs. We'll speak about it in the next slide, but it's really a piece of the intervention is limited reparenting. So it's for us as clinicians to really say what was missing, what didn't kind of cook all the way, and how can we infuse those experiences into the relationship that we have now. We support the healing of the early maladaptive schema, the softening of it. I like to share tiny toilets as a metaphor for my clients, where we speak about, if you've ever gone back to your elementary school and you looked around and you thought, like, when did they get these little potties? They were never this little when I was here. But of course they were little then, but you were little then. And so it recorded through the different lens that you held at that time. So being able to go back and revisit those experiences with a new perspective, with a different experience, with a perspective of being grown, changes them. And like I said previously, the goal in schema therapy is to reduce schema activation, to start to recognize when your schemas are activated and kind of say like, okay, I need to wait a little bit. My schemas are activated. I need to build some time in my response because I need to do some things that are going to lessen that activation and let me see things a little bit more clearly. And improve the ability to move into and to access healthy adult mode. It's also helpful for patients to be able to become aware of the coping modes that they have, or the coping, the way that their coping skills are influenced by their schemas, and to understand that schemas can reinforce themselves. And then ultimately, we want to help strengthen their internal therapist or healthy adult mode. Okay, so one of the first interventions for schema therapy is this limited reparenting. So the relationship is a change agent in schema therapy. Attunement is one of the most essential pieces and one of the most important elements of change. Schema therapists will often maybe be a little bit more willing to show their humanity, to show their realness, to show the fact that they are a human. May show a little bit of their own ability to navigate different things in the world. And a piece that has been helpful for me is always trying to keep that piece, that young version of that kiddo in mind when working with somebody and understanding their most extreme behaviors are often a way that they are working to get their own needs met. So I like this as well, this continuum, because we have the care and the guidance, the understanding of what needs might not be met, and the ability to show some of those and to meet some of those needs, while also having healthy boundaries, modeling those boundaries and limit settings, modeling some of those things that maybe weren't provided in the early experiences, and then being able to gently confront some of the behavior patterns that they see happening. Here are some cognitive strategies. So this example here, so the schema thought versus healthy adult self. This is an example. So this client wrote on two sides of the page. One was, what are my schema or my activated beliefs? And what are my healthy adult beliefs? And then put those in the columns. And so one of her schema thoughts was, you just need to stay away from people so you don't have to keep going through this. And she was able to challenge that belief with her healthy adult self by saying, the connections are worth it. Don't close yourself off. And I really love this exercise and doing this exercise in session with them because it's not just me challenging it. It's them accessing these two parts of themselves so that they can start to build the internal like strength and the internal ability to say, I can feel this way, I can feel this activated way, and I can also acknowledge that there's another part of me that can support my well-being. I really like the downward arrow approach as well. The idea of let's say that that's true. What would be the worst thing or the scariest thing that would result from that? And then they say, okay, well, nobody would love me. Okay, what would be the worst and scariest thing? Abandon all logic here. Worst, scariest thing that would happen from that. Well, then, I would die alone. And being able to validate what what is this extreme response or extreme belief really working to try and protect you from? Here you can see, I hope you can see it. I'll move myself so I can see it. You can Google schema flashcard. And this is a document that will come up. I love to do this exercise. It highlights, I will usually use this in anticipation of a triggering event. So if a person was going to go to a situation where they anticipate being highly triggered, we would fill this out in preparation for that. And knowing that it's going to ping a schema, and then what things they will need to challenge themselves to do, and what behaviors will support them through that. So it really leads them through being able to test it, and then have behavioral support, and to have some identified beliefs that are going to challenge that. I also like to have this arguing the opposition of a schema belief. So where we talked about the one client with the beliefs in the case study, the beliefs that she was highly endorsing. At some point when those come up in your session, you can say, okay, now I want to completely throw a monkey wrench in this, and say, I want you to be a lawyer for the opposition. Tell me why all of what you just said is not true. Your job is to argue the opposite, to show me evidence that the opposite is true. And it can really change somebody's, help to pull them out of that schema activation. There's a lot of experiential approaches in schema therapy, and often in these other approaches that are more experiential as well. And I want to say this because I was a therapist who sometimes struggled. Thank you, Ashley. Sometimes struggled feeling confident in, oh goodness, we are close to time, aren't we? Are we done at noon today, right?
Correct. Yep. And you're doing great.
Okay, thank you. So these experiential approaches are often really some of the biggest change agents. So let's talk about those. Oops. Creating a container. This is really not just centralized to schema therapy. Is actually something that is seen a lot in like EMDR. But first, being able to create a space that builds some healthy distance from their activation. So maybe that's a vault where they can put a lock on it, and they can spin it, and they can know that they're creating some deliberate space from those strong emotions. Perhaps a container or a safe place or an envelope can be an expression of being able to clear the fog, so to say. Building, bridging affect. So really starting to say, okay, what was it that activated the schema? What are you telling yourself about that particular experience? So often when somebody is highly triggered, there's a narrative or a description about what is happening, about interpreting what is happening. So being able to explore that internal experience. When did they feel like that as a child? What need do they have right now that would help meet what they're feeling? And this is another approach that can be really helpful in discussion. If you were to do a Google image search of the experiences that support that schema, what would you come up with? And how did you interpret those to yourself when you were little? And how would you interpret what was going on now that you're older? This is kind of more of that What I like about Schema Therapy is that there are opportunities for the therapist to service that healthy adult in the experience. I did this for the Alliance. I did this presentation for the Alliance, and then a therapist reached out to me and said that her client created this as part of the imagery rescripting. So she has, and she asked me to share, and I was thrilled to do so. So this is her eating disorder. He is Edward for her. And this is the client, and the therapist was able to say, what does it look like for me in your image to be there to support you? How am I doing that? And so she visualized that the therapist was there with her, that her best friend was there, that her dogs were there, and that her mom in heaven was also there with her, and that they were all there together supporting her against her eating disorder when she was eating. Brings tears to my eyes. So I love the idea. So it's the only intervention from parts work that I've seen bring in the therapist into the imagery. And I've seen that clients can often say things through you and have more empowerment even in embodying you in their imagery. I'm not going to do chair work just because I want to have some time for all of you for questions. Quickly, therapeutic writing, to the part and from the part. 8 Keys by Carolyn Costin is a great starting place for this. This is where I would ask that we throw in the EFFT book for the therapeutic apology. Therapeutic apology is something that I've used time and time again. It has a beautiful script for demonstrating how somebody might put themselves into the place of the person that they are apologizing to, what they might have expected from that person's experience of being in that place, what they intend to do differently. And you can I've used that script in writing from the part, writing to the part, writing from healthy self to the wounded child. So it has so much applicability. You can Google it. I didn't find that script was available, but the book is worth buying and incorporating. What I'll say here about experiential approaches, just from my own experience, I find that clients do better when you ask them to just take a second and close their eyes, to be present with whatever sensations are there in their body. I also like to say, it's going to feel weird. That's okay. We're just going to roll with it. Sometimes I say, it's cool. I won't look at you when you do this. And then I have them kind of center on the here and now, the fact that they're there with me, and that they can always come back to the fact that they're in the here and now with me. And then some of the things that we do during that space and time is, how do they want to take care of their parts? And we do a lot of this discussion when leaving the imagery. And how do they want to leave the system? What does the system need to know about them being the healthy adult that's leading them? And how can they leave with that trust? Okay, here are many of the resources that I use throughout the presentation. You have the couple that I mentioned also in the discussion. And then I'm going to stop this and hopefully make some time for questions if there is any. Let me throw this there too. I'm so sorry that we ran out of as many minutes for questions as I had hoped, but please do not hesitate to shoot me an email if you have more questions about things, or you would just like more discussion about this.
Thank you so much, Rebecca. And I want you to be able to look in the chat and see all the love that you're getting for all of the wonderful imagery that you used. And I know several members of the audience said that they were also brought to tears by the information you provided with us today. So again, thank you so much, Rebecca, for such an incredible presentation, and to all of you for sharing in this space with us today, for all the wonderful questions that you provided. I also want to thank again all of you for joining us today, all the questions. We had such a wonderful presentation. We also have another talk coming up this June. It's another wonderful presentation that's on our horizon for our Within series. The topic for June is Beyond Binging, Treating Binge Eating Disorder in a Virtual Setting. And that will be available on June 28th at 12 p.m. Eastern Time. That will be presented by one of our very own therapists, Carrie Ann DiArino, and the wonderful Dr. Wendy Oliver Pyatt. For registration for those as well, if you want to attend that event, that'll be available on our website and on the social media platform. And again, that will be on June 28th at 12 p.m. Eastern. We hope to see you all there. And again, thank you all for joining today, and big thank you to Rebecca for such a wonderful presentation. Have a great rest of your Friday, everyone.
Thank you, everyone.